Well, it's now 3 o'clock, so I think that we're going to begin because we have an online presence today, and I want to make sure that we start on time so that the people that are joining online do know that we're here. So good afternoon, everyone, and welcome to our first Community Chats activity. Whether you're joining online, welcome, or here in person. So we have a few audience members, so thank you all very much for coming. I'm Julie Mitchell, the Chair of the Community Engagement Subcommittee here at SALHN, and my first honour today is to welcome Teresa Francis, who is going to undertake our Welcome to Country. You can take the mask off.
Thank you, Julie.
Thank you.
Hi, everyone. First of all, I am not Ghana. I am a visitor to Ghana country. My background is I am Kanurikan, which are the paperbark people in the Northern Territory. And I have connections with Gurindji as well as Torres Strait. I'll read the acknowledgement. We acknowledge that the Kaurna people, as the traditional custodians of the Adelaide region, on which I work and which SALHN is located, we pay respects to elders past and future, present and future. We recognise and respect their cultural heritage, beliefs and relationships with the land. We acknowledge that they are the continuing importance of the Kaurna living people today. Also, we pay respects to the cultural authority of other Aboriginal and Torres Strait Islander people visiting and attending from other areas of South Australia and Australia. Thank you.
Thank you very much, Teresa. I'd also like to recognise that the Kaurna people are the traditional custodians of the Adelaide Plains and recognise their deep and enduring connection to this country, and I pay my respects to elders past, present and emerging. Today I'm joined by some panel members. First on my right is David Morris, who is one of our executive members of the SALHN management team. I have Dr. Terry Sweeney, who's sitting in the middle, CMG. Terry is our newest, or one of our two newest SALHN board members, and he is the CEO of Digital Health Cooperative Research Centre. So I'll let Terry explain a little bit more about what the Digital Health Cooperative Research Centre is when we get into the Q&A. And sitting right next to Terry is Associate Professor Belinda Lange, who is the Research Lead for Technology in the Caring Futures Institute in the College of Nursing and Health Sciences. And Belinda is also a board member for the Australasian Institute of Digital Health. So today, besides having a discussion with panel members, we are actually officially launching our community engagement strategy. So this is a piece of work that has occupied quite a few people here at SALHN for quite a while, so it's really pleasing that we've gotten to this point today. Caring for our consumers takes an entire community, our staff, including clinicians and patients, our relationships and our research, all support our community's health. Our work at SALHN is driven by what our community needs. We already partner with consumers in a very robust consumer engagement framework, and that helps us to improve health services in many different areas here at SALHN. But we want to broaden our community connectivity to help shape our local healthcare system now and for the future. In developing this strategy, we spoke to a lot of people that are connected to SALHN, and they talked to us about the things that are important to them about their healthcare now and what they are expecting into the future. And we used that information to put together our community strategy. So I'm very thankful that people took the time to participate and connect with us and really help to shape this strategy, which we are launching today. So we want to create strong, trusting and meaningful relationships and achieve excellence in person and family-centred care. And this engagement strategy, this community engagement strategy, is our blueprint for the way that we go about that. So Community Chats is the first opportunity that we have to create that purposeful connection with our community, and it's pleasing to me that we're actually able to do that at the same time as launch this strategy. So today on our panel we have some subject matter experts. So I'm sure that when I introduced everybody you would have understood that there is a theme here, and the theme that we're talking about today, the question that we're going to talk about, is how can digital inclusion have the potential to fundamentally enhance the way we deliver healthcare services and engage with our patients, staff, community and citizens? So why are we talking about digital adoption? So digital adoption and the digital world is one of the biggest influences on healthcare in the current world we find ourselves. COVID has accelerated the uptake of digital technologies and triggered a number of advances that perhaps without COVID we would have been waiting for some years to land. So telehealth, I'm not sure how many people have participated in telehealth, transactions with medical professionals, virtual consultations and virtual hospitals are all becoming something that we are experiencing in our healthcare model. We know that redirecting some hospital-based treatments to people's homes through telemedicine and mobile health is transforming health services and people's experiences of health services. And I think a really good example of that is something that you might have seen on television, and that is that many people are now having chemotherapy treatment in the comfort of their own homes rather than in a medical setting. And I think that the information that I've received from people that have participated in it is that that has greatly helped not only their recovery but their state of mind throughout, the situation where they were undergoing treatment. But let's unpack how patients can get better treatment with virtual reality tools, electronic sensors, wearable medical devices, telehealth and 5G mobile technology. So I have some questions to ask of the panel, and my first questions are to David. David, can you talk us through how COVID accelerated digital adoption at SALHN over the past months or years now, 2 years nearly, and how technology is helping us during a pandemic?
Try and keep social distancing in a hospital, how we can try and free up waiting rooms, how we can protect staff from a pandemic by having a workforce that can have a component where they can work at home but still provide the expertise and some of the cognitive consults that they do from home. And really importantly, from a patient point, providing more choice and having to come every time into a physical facility. You certainly need to come into a physical facility for certain things, but we found that there's probably 2 or 3 main reasons people will come into a hospital traditionally. One is to have a level of assessment, and that assessment might require some diagnostics and an X-ray of some of those things. So there's different options to coming into a busy hospital where there might be other sick people to have some of those diagnostics. So across the world, there's been what's the role of mobile diagnostics and what's the role of point and care testing to support some of those components. Then there's procedural things like surgery you're not going to have done at home. But often people will come in to see a specialist medical or another clinician to have an opinion or a consultation. That more and more is being given as a choice now. You can have that from the comfort of your own home, or you can come into hospital for that. And I've just got a really simple example of I have high cholesterol, have to get cholesterol tablets every 6 months, and it's really inconvenient for me to book into the doctor, drive down there, say the same thing that I always do, get given a script, drive to the chemist. In a pandemic world, I was able to call, get the consultation, get sent a QR code with my script. It was all done in about 10 minutes, and it just made life much easier for me. When we first had COVID come and we got a few cases and essentially had the first shutdown, you might have heard that emergency departments were pretty quiet. And we were really worried about some of that because we didn't want people to put off care for what was really important. And children were one of the biggest areas that we had the drop in SALHN by about 30% reduction. What we did at that time in SALHN is then we opened up some of those consultations if people didn't want to come into the hospital and need an opinion rather than a procedure. They could get that done via their phone or via a video consultation, and that just made life much easier for people. So I guess just to answer the question, it's changed a lot. We did have workforce components where we'd split surgical teams and medical teams, so some were physically in the hospital and others were at home. We were doing things like virtual ward rounds so that we could have someone sitting at home providing a ward round through technology. And it was just a way that if some of the learnings interstate and overseas were the workforce. If you had sort of a pandemic go through a workforce, you can lose some really specialist people that have to then quarantine at home. So it enabled us to have a way where we could still, have that expertise being provided, but in a way that we mitigated the risk of losing a lot of people at once. So, so for me, I'm seeing the technology much more about additional options. It doesn't replace face-to-face interaction. Really important that still occurs, but it does provide alternate options to interact, and actually in a way that's sometimes easier, in a way that we can do 24/7 from your home, from your residential care facility, from your country hospital, even to the point of how we can support higher dependency and other components from this hospital to potentially somewhere in country. We can provide that by providing that expertise and monitoring. So it is changing the world quite significantly, but not in a way that, I think in a way that provides more choice than less. And probably that's where I'll stop.
David, you've touched on learnings in answer to the first question, but what are some of the learnings that we have had at SALHN here in relation to using technology across our health service?
I guess it sort of extends what the learnings would be in a normal interaction. One size doesn't fit all. People have different pieces of technology. People have different ways they like to interact with that. Even just some of the simplest things of if you're having a consultation at home and you might be busy looking after the family and children, it was sort of how you would negotiate some of that. Having really simple, apps and other components that people can use. Recognising they're actually still using bandwidth and other components when we're using those things. So that needs to be taken into consideration with what types of plans and things people will have. But probably just the most important part is that it was new to start with. Some people were certainly frightened by it, I think is probably the right word, or unsure. I think the more people started using it, the more they felt comfortable with it. But we also do have a role to support people to use technology or not use technology if that's what they want to do. And it wasn't just in learnings from a patient or a citizen point, but certainly the way our staff have interacted has been quite different as well. If I look back 2 years, just the meetings we used to have now, everything is Teams now because it's easy. You don't need to leave one hospital to come to another. You can do it from anywhere. So lots of learnings, and they'll continue to learn. But I think it's really been about this is a different way we provide services, and we've got more options. But we still need to be really cognizant that not everyone has got a phone, and not everyone wants to interact that way. And we're certainly not. We're certainly not saying that this is the only way. This is just another way of interacting, and we'll try and make it as easy as we can as we move down these lines, but knowing that there's still a physical facility if people need that.
David, what if patients haven't wanted to use technology and prefer face-to-face consultations?
Yeah, so we haven't. We've given the option each time. That option has been particularly for outpatient appointments. For other appointments, you can have them, via a consult, or you can come in, and that's fine. We have had people come in. We give that option to our clinicians as well, because it's really important. Some things aren't appropriate to be done virtually, and even just is it the first appointment with someone, or do you know them quite well from that component? So there's been no requirement. This is the only way you can receive a service. It's just this is another way you can receive a service. Some people have adopted it really, really well, but also some people think that I'm actually not very, computer literate at all. My 16-year-old daughter does most of my setting up for things, but sensors around cars have been used for years to keep people safe, and now they're starting to use sensors at home so that people can have technology within their house or in their environment. They're not directly interacting with it, but it is an enabler to support care, and that's what we're seeing more and more, that the technology is sort of to the side. You're not having to necessarily interact with it heavily. You need to give your consents and things to use it, but the technology is part of the environment, and we're seeing that in most industries now.
So you can be passive users of technology, and I know that in the aged care settings that is something that's already happening. So people's movement is being monitored without them having to have a device, but they can be helped if help is required because it's known to somebody that's monitoring what they're doing. So that's a big game changer in lots of ways.
game changer. And I think people think of, you might initially think of what does home monitoring look like and think there's a camera sitting up in the corner watching you, and that's absolutely not the case. It might be something attached to a PowerPoint in a fridge so that it knows if the fridge hasn't been open for a day or so.
Yeah.
You might give consent for it to go to your daughter or your son as an alert, or to your GP. Importantly, you give consent for each of those things that you want either to be in your house or in your environment or not. But there's some that can be voice activated. So if you have a fall and you call out for help, then that can actually send an alert to someone of your choice. So the technology really is there to pick up, your environment, your situation, and to sort of support you around that. And I think we'll see more and more of that, again, at people's choice. But it's all about some of that environmental and support monitoring that's been done in manufacturing, in cars, in other places for years before, and now is moving more and more into health.
Thank you, David. My next questions are for Terry. Terry, can you give us a quick overview of your role as the CEO of the Digital Health Cooperative Research Centre, and maybe start off with talking about what a cooperative research centre is?
I think I'm on. Yes,
Yes,
I'm
you
on.
are.
Well, I've only been in the job 6 months, so I had to look up when I was offered the job what a CRC is, a cooperative research centre. So there are 26 CRCs around the country. They've all been funded largely by the Department for Industry, Science and Technology. And the idea being that each CRC focuses on an industry and helps to solve problems in that industry, but at the same time look at the economic development of creating jobs, stimulating the economy and attracting global talent. I happen to run the Digital Health Research Centre. We're actually the largest digital health collaborative in the world. We have funding of about 200 million over 7 years. We're 3 years in, and we have 74 partners. So it's all about using the ecosystem to solve problems. So we're not the smartest people in the room, but we're the connectors. We kind of act as an intermediary service where we work with frontline healthcare, and every state-based health authority, including SA Health, is a partner, as is the Federal Department of Health. And basically they come to us with the problem, and we look to see how technology can help not either solve it, partially solve it, or support making things better by using digital. And 16 of our 74 partners are universities. So we have Flinders and Uni SA here in SA. We have industry partners like Telstra Health and Bupa and others. And as I say, pretty much all of the health providers in Australia are partners as well. We try and bring all the pieces of the jigsaw puzzle together to solve those problems, but do it in a way that's, might be solving a frontline problem, but do it in a way where we have opportunity to commercialize. So can we try out a pilot by looking at technology to improve patient flow in a hospital setting? And if we get it right, what's the opportunity to commercialize that solution and help promote that to other areas, either nationally or internationally? And that's where the economic development aspect of what we do comes into play. I live in Adelaide, despite the accent. I'm a proud Adelaidean, and you all sound more English than I do, and I'm English. And we were a Sydney national organisation, but the entire team was based in Sydney. But since I started 6 months ago, surprise, surprise, we now have a national innovation centre in Adelaide, which is at Lot 14, and we're growing the organisation there. So that's kind of who we are and what we do. We focus on innovation and commercialisation of healthcare technology.
This isn't a question that's here, so I apologise for that. But how did you first become interested in digital and digital health? What's your journey to get to this point?
Yeah, it's. I actually spoke at Adelaide University recently about the topic was career pathways, and my career pathway is just really weird and it's a little different, I think. But like many things in health, and it's always funny when people say, "What do you do? What industry do you work in?" I always say healthcare. I never say technology because I think it is healthcare. For me, it was a personal thing. My grandfather in the UK, who was my father figure growing up in the northeast of England, died quite suddenly of cancer, and we subsequently found out that there were a large list of things that didn't go right. And no one was suggesting that he could still be around today, but there were things that could have maybe prolonged his life and gave him a better quality of life. There were things that didn't go right at the diagnosis stage, at the treatment stage, and they were largely down to the fact, through no fault of the oncologists, but they didn't have the data that they needed to make the best decision possible for my grandfather, and pretty much all of us, I think, would probably have a similar story. So for me, I kind of got interested in the technology as a way of how can we use it to aggregate all of that complex information to give the frontline healthcare worker all of the available information that they need to make an informed decision. But also at the same time, how do we make that sometimes highly complex information easy to understand for the patient and the family and the carers of the patient, to make it easily consumable and to help them make an informed choice in how they, to make them feel part of the process. So that's kind of what got me originally interested in using technology in a healthcare setting.
Oh, good. So how can digital technologies help improve the patient journey? So, you've started to talk about that in your own setting. What do you know now?
I think, and I apologies if anyone's heard me talk before, because I've used the same example. Jenny, you've heard me say this a few times. I use the same example about healthcare. I think is one of the last industries where the consumer is not king or queen. In any other industry, whether it's retail or banking or financial services, it's often a good experience. It's consumer driven and consumer led, and the consumers have easy to digest information to make an informed decision. The interaction is often quite a pleasurable one. There's a differential kind of response, as David alluded to. If I like to shop online for my shoes, then that I can do that. If I want to walk into a store, I can do that, and I have a lot of choice and I have a lot of information to be able to make the choice. In healthcare, I think we're catching up. I don't think we're quite there yet. I think often as consumers, we feel like the healthcare service is being imposed upon us, rather than actually we've been involved in making a choice as to what that service is, who is delivering that service, and how it's delivered. And that's where we get into the technology. As you mentioned at the top of the conversation in your introduction, COVID has accelerated things, and I think things like telehealth, COVID has accelerated that from a safety point of view. It's less safe to go in and see a clinician face to face, so let's do it over the telephone. But for me, I'm not as concerned from a safety point of view. For me, it's convenience, and I want to have the same digital service, but for me, it's a convenient thing. To your point, David, if I have a ongoing repeat prescription, I don't want to have to go in and physically make an appointment to see my GP, to wait half an hour, because invariably we're going to wait half an hour. No fault of the doctor, but it's not hard to do live tracking of their schedule to give me that half an hour back, but we often don't have that yet. And I think we're just willing to accept it as consumers. But where we see, I think, I'm going on a bit, aren't I? But
no, not at
I
all.
think in Australia we're going to see we are seeing a transition from activity, and everything follows the money, right? So we're moving from an activity-based model where healthcare providers get a fee for delivering a service, regardless of how effective that service was. We're getting to a point where we're moving towards value-based care, which is, 50% of healthcare in the US is value-based, and the consumer has a much bigger voice there than they do here. That's because once a healthcare service has been delivered, before it's paid to the healthcare provider, we ask the patient, what do you think? Do you feel like you got a good outcome? How was your experience? And that people talk about PROMs and PREMs, patient-reported outcomes and patient-reported experience. The voice of the patient on how effective the delivery of the service was to them is becoming more and more important, to the point that the money will then follow that. So I think that provides an opportunity to us here in Australia, where the consumer voice will be taken much more seriously, because ultimately funding is on the line as to whether that patient was satisfied or not, or that consumer was satisfied or not. I don't know if I answered your question. I went on a very long
you did.
time.
To just extrapolate some of those ideas a little bit further, what do you think the future opportunities are for digital healthcare? What do you think's coming?
Well, the thing that gets me really excited at the moment, and we're doing a little bit of work on this in the CRC, I'll get a bit boring about the technology, but then I'll try and bring it back to make it relevant to the real world. There's a revolution going on at the moment in computing, right? We've moved from these traditional systems that are logical, they work on structured information and they're rules based. You know, if the patient's age is X, then do this. If it's Y, then do that. Very logical and very structured. And we're moving into this era of artificial intelligence and machine learning, where modern AI systems can read 4 billion pages of unstructured information per minute and assimilate it in under a second and give a meaningful insight from all of that information. So I'm really excited about how that technology can be used to give frontline healthcare workers the information they need to make a better decision. Globally, medicine, less than 50% of medicine is evidence-based. So pretty much every second decision that someone makes about someone's health, diagnosis, treatment, cure in medical research, less than 50% of that is based on evidence. And that's just because until now, we haven't had the technology to unlock that information. And now we do. And associated with that, I think, is this and I'm getting really boring now, but there's this evolution in microprocessing, and we're getting into what's called brain-inspired computing. So the ability to have a microchip that is based on the neural pathways of the human brain, and you know, we talk about wearables. I've got a Fitbit, you know, and it's kind of cool and it tracks some of my information, some of my health information. It can do some basic functionality on the Fitbit. If it needs to do anything more complex, it does it on my phone. But ultimately, it'll go up to a computer in the cloud to do the highly complex processing. But we're seeing advancements in microprocessing which will allow us to have real-time decision making on our bodies, on our sensor, and we call that we're moving from wearables to thinkables. And it's important to have that real-time processing, because if you think of things like, if I have epilepsy and I've got a device that's on me that in almost real time can tell me that I think that you're gonna have an episode here. Fall prediction in the elderly. You know, based on certain statistics and information, we predict that you've got a 95% chance of having a fall in the next hour. Go and sit down, or, you know, go get with a carer or a family member or whomever. So that real-time processing of information and the ability to predict an adverse event before it happens and alert that person to do something about it, I think that's super exciting, and it's in the near future.
Absolutely. I've got some questions now for Belinda. Belinda, I understand you've just been appointed to the Australasian Institute of Digital Health as a board member. Can you tell us a little bit about that organisation and your involvement?
Sure. The Institute is it's one of the leading independent bodies for digital health in Australia, and it's part of a global network. It's a not-for-profit institute, and it really brings together people with expertise and interest in health informatics and digital health. And its members are quite varied in terms of background. So we have clinicians and academics, managers, innovators and people from industry. So it's really a unique space to pull together some of that expertise and really work towards a central vision. And that vision is around healthier lives, digitally enabled. And so what I really like about that vision is that it has that focus of not the technology in the centre, but really about connecting with the patient-centred approach. And that sort of pulls together really what we want to do around having digital technologies that enable us to provide care when and where it's really needed. I guess the Institute itself is really involved in some leadership activities and advocacy, setting standards and policy, providing sort of input into policy, but also really one of the bigger strategies of the Institute is building capability in the healthcare workforce. So really being able to support healthcare organisations and the future and current workforce to be prepared to contribute to some of the changes that we're seeing coming, but also being prepared to work within the newer kind of digital ecosystem that we're starting to see. So I can see that SA Health has recently become an organisational member of the Institute, and I think that that's a really great step on that kind of digital transformation journey.
So, Belinda, you're also involved on your own terms in research. So you're doing some research about how clinicians and consumers use technology in both personal and clinical settings. Do you want to tell us a little bit about that?
Sure, yeah. So within the Caring Futures Institute, we're really interested in supporting people to provide care for others, but also, to support people in their own self-care activities. And the research that I'm really interested in is just finding out more about how people use technologies in their everyday life. So we want to know what technologies people are using, how they're using the technologies, and gather more information and a better understanding of how comfortable people feel using technologies. So we talk to clinicians, we talk to consumers from different settings, and we want to find out not only sort of how people use technologies in their own personal life, but then their experiences of some of the touch points of using technology in the healthcare setting. So what's worked well, what hasn't worked so well, how can we provide better support or training or perhaps some potential solutions that might, solve some of the challenges or problems that people are coming across. So we've done that now in the inpatient setting in hospitals, and we've also done that with people with brain injury in the community setting.
Okay, thank you. This is about a particular technology.
Sure.
How can consumer technologies such as virtual reality be used in this, which is something that interests me a lot?
Yes, virtual reality. I guess virtual reality takes many forms, but I think what most people would be familiar with from the movies and perhaps some of the more recent technologies that are available is the virtual reality headset. And for those of you that maybe haven't used a virtual reality headset, it's like a pair of goggles that you put over your eyes, so sort of like a scuba diving mask, and then in front of your eyes are a couple of screens. So it blocks out the real world around you, and it takes you into a virtual environment or a virtual world. Now, what you can display on the screen is really up to your imagination. So you can use video, you can see the normal sort of computer desktop, or you can view more game-based sort of environments, or through to really functional, realistic environments. The neat thing about a virtual reality headset is that when you move your head, you can look around the environment. So it's not just looking straight in front of you. You're actually immersed in the environment. And you can use controllers or other types of tracking devices to track the body and the hands, so you can actually interact with virtual objects within the virtual environment. So I guess already from that description you can think that actually there's probably quite a number of uses for this type of technology. It's been used in entertainment industry, for training, for education, and certainly there are plenty of uses in the healthcare system. But I've been working with virtual reality headsets in particular since around 2003, when we used a virtual reality as a distraction tool for children who were receiving procedures in the emergency department. So really trying to block out what was going on around them and divert their attention to something else, to take away some of that pain, but also the stress and anxiety around the procedures that were taking place. I guess that system was a bit clunky and expensive at the time. It was around $15,000, and I carried it around in a big suitcase, and we used a version of Quake, which is not very engaging. But since then, fast forward some 15 years, and we're seeing headsets that fit in my handbag, and they're around $400, and definitely seeing more of these systems used for pain distraction, in particular in adult and paediatric settings. The other use that we've been working on is with an industry partner, Katana Simulations, and they've developed a virtual kitchen. So this is a more realistic environment that you can interact with, and thinking about using it in the brain injury setting. So we've been working with clinicians and people with brain injury to find out how we might be able to use this technology effectively to support recovery. So when you've had a brain injury, it's really focusing on relearning everyday activities. So making a cup of tea, making a sandwich, and usually you might do that in a kitchen setting in the hospital, or maybe someone will come to your home and help you. But what we can offer in virtual reality is the opportunity to practice in a safe environment, and opportunities to practice when other people aren't around, so that you can actually, maintain some of that and improve, I guess, on the activity in between sessions. So that's really exciting, and another sort of potential use for virtual reality. And then finally, another use that is something that could be very important around training of our clinicians. So we often train on the job, and it would be useful to have opportunities for practice in a virtual environment before actually being let loose on patients. So I think there's lots of opportunities for virtual reality.
Thank you, Belinda. Back to you, David. What have your conversations been with clinicians across the state on the development of virtual reality and digital technologies in terms of healthcare services, and how do they feel about integrating digital technologies into their practice?
As I say, the driver of it has sort of been, probably going to Terry's point, the convenience factor, but also then what the possibilities are with the technology enablers. Certainly in country, there's a lot of discussion happening at the moment around sort of hub and spoke type models of how you can sort of bring technology from metropolitan Adelaide and the expertise to the countryside. With potentially remote monitoring as well. Santosh Vigasi, who is the Chief Medical Information Officer for the state, but also a intensive care doctor, was telling me a story where he used to have to do the trauma calls where you would fly out to country, you'd get a conversation on the phone about how the person was. Couldn't physically see them, so that was always difficult. You'd fly out there, and you might get there and think, actually, the patient wasn't as sick, or I could provide some advice and they can stay where they are. And he said that took 4 or 5 hours of his time as a senior clinician, but it was also 4 or 5 hours where that patient waited for some decent amount of advice on what they were needing to do. Invariably, people get brought back into city because it's been clunky trying to go back. But now you've got the potential where you can have multi-channel, so different types of video where you can see, you can interact. You can have technology that, the same as me standing in front of Terry here, that I would see Terry on a screen and I might see his ECG, his cardiac monitoring going on. I would see his blood pressure. So everything you want to see is there in real life and in real high definition video. So the possibilities of that type of technology now will change drastically the way we provide care, I think, but also for regional facilities that don't necessarily have doctors on after hours, or who might be in, Kangaroo Island and quite remote. So the way you can link in with technology and support and actually see all of the patients and all of the components is, it's got a lot of excitement happening, I think, because people think it's good. People can stay, potentially receive care in place, so in their home, in their regional facility or in their region, not necessarily having to come to Adelaide. Come to Adelaide each time. But then you take that to the scenario of medi hotels, and sort of as borders start reopening and we're going to be going into a sort of a living with COVID world, which will change things again, that monitoring level that we can do at home to keep people safe, with potentially a little, oximeter that measures oxygen, so that, again, we know that if the oxygen saturations are a certain level for a while, then the person is generally okay. So we can get the feedback from a phone call or a video to say, I feel fine, but then you can also see some of the biological monitoring. So there's excitement in more the possibilities that it enables people to do, and certainly we as a SALHN or a Flinders that can look after, from beginning to end of life, the whole scope. The expertise or the support we can provide to a number of different facilities is sort of exponentially greater with the technology enablers than certainly what we've traditionally been able to call with phone calls. And that's where I'm sort of seeing the next, the next stage is that really ramping up and those levels of support really increasing. You can do it with phones and others, but there's different technologies that as they're sort of developed will go through. And actually the oil and gas industry have pioneered some really low, they can have really high quality video in really low bandwidth areas, and that's always been one of the real challenges. If you've got really grainy video in the back of a regional facility, but now technology that's being done, in oil rigs, in oil and gas, will be leveraged across health and other components, and areas like Terry's got and Belinda around some of the partners. You just bring in partners and say, what's the opportunity for health, and it's going to be significant. So.
Thank you. Terry, we've been speaking today about, how a digital environment can enhance healthcare. Where are you seeing globally great examples of this in healthcare systems?
Oh, yeah. I think in terms of organisations, the Mayo Clinic in the US is probably number one. And I know David's been speaking with them about how we can leverage what they're doing over there here. I think they're probably one of the better examples of a digital forward-thinking healthcare organisation. They've partnered with Google to develop their own health platform. They use a lot of kind of AI and machine learning. They're very advanced in terms of their virtual care and virtual hospital offerings or out of hospital offerings. So I think as an organisation, they're probably right at the top. I think geographically, Israel, I think, is always number one for me. I think they're just such an innovative country. They've had to be because of a combination of they don't have any natural industry. There's no natural resources there, so they've had to use things like the digital economy to advance their own economy. And thousands of years of oppression also adds to the we'll show the world what we can do. So I think that lots of exciting things going on. There's our counterpart in Israel is called Sheba Health and Medical Research Innovation Institute, and they're just doing some absolutely wonderful things. So there are things that we can learn. NHS in the UK and NHSX, which is their innovation arm, are doing some fantastic things around data. A lot of innovation where the country largely has a single provider, as we do here. We have private health, but largely it's the government that is the healthcare provider in Australia on over 70% of occasions. We need to have the kind of legislation and the policy to kind of back up what we're doing in digital and to update it. So, as an example, we talk a lot about the pitfalls of sharing our information, right, around data privacy and sovereignty and security. In the UK, for example, they've just passed new legislation to allow GP health data, patient data, to be used for medical research. Here in South Australia, really, unless you have an SA Health badge, you can't access EMR data, for example. So we've got this beautiful multi-million-dollar research organisation on the west end of North Terrace called SAMRI that can't access that EMR data to advance discovery in medical research. So I think that's an example of where policy and legislation and regulations need to kind of be an enabler to use the technology for the greater good. Again, I don't know if I answered your question.
Yes, it certainly does. Belinda, we've spoken a lot about the benefits of technology, but there are people who don't use it and don't access it and don't want to. What has your research spoken to you about that? What are you finding, and how do we address that?
Yeah, so I think the technologies that we've seen or heard that people are most comfortable with are mobile technologies, using tablets, smart TVs. A lot of people feel comfortable using smart TVs, but some of the challenges, I think, around using new technologies is around expectation. So when we're doing research and with trying out new technologies like virtual reality, some people are interested in it or, just want to give it a go, but don't really see that it has a place for them in their care or in the recovery process. And so once they try it and say, give it a go, I think it sort of opens up their minds to the possibilities. So I think when we're talking about using or introducing digital technologies, it's really important to set expectations that give it a go. It's not going to be perfect the first time, and be open to receiving feedback and making changes and trying again. So getting that conversation started, setting the expectations up front, I think we've had a lot more success. The other thing that I think is really important when there's a little bit of resistance to using technologies, particularly from clinicians, is having a champion, having someone who feels comfortable with their technology, who's on site, who people can go to actually ask questions and get some brainstorming and some answers around it. So it's less about pushing a technology onto somebody, more about getting them to give it a go and work through some of those challenges.
Thank you. We've got 15 minutes left in our session, so I would like to open questions up to the audience, and people that are participating online can also participate. So you can send in a question. So you just have to scan the QR code that's up there on the screen. Otherwise, you can put your hand up and ask a question, and I'm sure one of our panel members will happily answer. Any questions from the audience?
Probably to David, how do we keep the momentum of telehealth up? It feels like being in clinical space and looking at the numbers, the telehealth is dropping off as people get back to the face-to-face they're comfortable with. How do we keep that momentum? How do we make it almost the forefront of the way we're going to deliver a service in the future where it can be safely delivered?
I'm just going to repeat that question so that the people listening in can hear it. But basically the question is, and it's a great question, how do we keep up the momentum of telehealth? Because there is evidence that it is dropping off a little bit. And that question is for David.
Yeah, thank you. It's got to be easy to use, and I think that's the real key thing. Certainly when COVID first hit, and it's 18 months ago now, we went very strong on sort of telehealth, virtual health, different types of options, and sort of then as the pressure came off a little bit and things got back to usual, people went back to what they're most comfortable with, because that's what, I think it takes 3 months to sort of relearn a habit. So we have a role within SALHN and certainly as part of the leadership component to still support that, because getting back to Terry's point, this needs to be all about patient, citizen, consumer choice, and that choice is really, really important. I think we're starting as we move along now to get some of the enabling technologies that will make life easier. It was clunky to start with, and we were doing that, and we haven't got the best history of and I say this, across the world of putting in new systems that sometimes make life a little bit harder for the people that are trying to use them. So it's really important for leaders in business, in industry to consult and engage enough to find technology that works well, is easy to use, can be supported. But fundamentally, we need to have the decision point of what's going to make it easier for the consumer to access our services, and then how can we design them in a way that they are easy to access. So I think there's certainly some reinforcement component to that from a health point, that we need to be providing different options. We need to listen to the community. The community is telling us that. And I just think that's part of the leadership thing we've got to do. But again, if we haven't got fit for purpose, equipment, infrastructure, and other components that are going to make that easy, then it's always hard to bring a workforce along. So that's going to be really important.
I have a question that has come in. What are wearables? Perhaps you might like to answer that, Belinda, or Terry,
Well,
whatever.
I could be referring to shoes or jackets, but in this context, it's a device that you wear on your body to help you with your health and well-being. So an Apple Watch or a Fitbit or similar would be an example of a wearable. It's something that you literally wear on your body, often doing some kind of monitoring and feedback on how you're doing. So that was the content. When I mentioned thinkables, wearables are kind of currently quite dumb and they're limited in what they can do, but they're going to get smarter and faster. And that's when we talk about thinkables.
Thank you.
So I was just going to sort of add to that. There's been a little bit of information came out recently that in the future, probably an electronic medical record that I think Terry and Belinda both spoke to before will probably make up about 20% of the information about me, the human, whereas some of the things I'm wearing or interacting with is probably going to be 70 or 80% of that, and that might be your Apple Watch that measures how you sleep and your heart rate and your blood pressure and all of those types of things. And more, particularly in the States and in the UK, people are going home with care packages that is an iPad or a tablet of some kind that might have a blood sugar level monitor or something else on it, so that they can manage their own care, but also link into the healthcare provider as needed. So becoming more and more, and the thinkable, I think, is that it's clearly the next level on that adds the AI to it.
Sorry, and just to complete that, I think that what that actually does is provide information in between some of those time points where check-ins would normally occur, and so we might be able to capture points, important points where we might be able to make changes earlier, and that could have a really significant impact on health and well-being.
Actually, that's a really good point. That just reminded me of something that, referring a little bit earlier about AI, and AI is only as good as the data you use to train the algorithms. And one of the things we don't get is that feed. I have a problem. I go to my doctor. My doctor diagnoses the problem. I might get some medication to help with that problem. And if that worked or the problem went away, we never find out. I don't go back to the doctor and say that was great. I only go back if something went wrong. So I think it's as important for us to collect information about what worked well as what didn't work, so we can use all of that to inform the decision the next time someone presents with the same situation, with the same characteristics as me. So thank you for the reminder on that one.
I have a question that's come to us online, and I'm not sure of the context of this, but I'm sure you will all know. How does the Monash experience help with the South Australian plan? I'm not sure what the reference is.
No. Monash University, Monash Health.
Yeah.
Not quite sure. Not sure about that. David,
Maybe
does that
that's
ring any
something that we
bells?
can take on notice.
Yeah.
I have another question.
If they could message back in with what it is.
That would, if they can
good,
provide
yeah.
some more information, that would be great. But a second question that's come in online.
And Julie, probably just the only thing, I mean, there's some of the learnings from around the world. RPA's just done a virtual hospital. Fiona Stanley's just done a virtual ED. There's lots of models. Let's say Sheba, Intermountain. There's lots of models around the world and around the country that are sort of leveraging, so all of those learnings are being picked up, and they sort of, we in SALHN have sort of looked at what's the safety component to that from staff, what's the quality component from a patient point, what's the delivery, so what's the ease of access. So we sort of look at it under different lenses to make sure that, it's appropriate to to the environment, but certainly around quality of service, how we can deliver it in different ways and make it easy to use, and how we can make it so that it keeps our staff safe as well.
And we've never
really
been
important.
better connected to actually capture those learnings and apply them in any different setting too, which is fabulous. I haven't had anything more about the Monash experience, so I can't add anything to that. So this next question is, in your opinion, how well are we currently including all end users and consumers, so consumers and clinicians, in the development of new technology products? and is this process agile? So that might be something, Terry, that you're, and Belinda, that you're quite immersed in.
Yes, I think we could do better. But I think there are examples of groups, companies and researchers who are doing that well. But there are still examples of people designing technologies from the sort of ivory tower and not including consumers. It's really important that anybody who's going to have some touch point with the technology, some involvement with the technology, is able to provide some input and feedback along the way. So often clinicians are left out of that loop, but it's really important that if we're expecting a digital technology to be used by clinicians to support client care, that actually they're involved in that process from the beginning, preferably. And everybody brings their own expertise to solving that particular problem. And sometimes the problem is not as clear as you think it is until you get down to some of that detail. So definitely we should be advocating for and leading the way in engaging all key stakeholders from the very beginning of either developing a technology or implementing a potential technology into practice, because it really needs to fit the system, fit the workflow of the clinician, but also serve the purpose of improving the care that we provide. And there needs to be a balance. I think it's not always going to fit exactly, but everybody having some input into that process is going to be an important start to that, getting that right.
A couple of really good questions have come in. A question here and a statement. This is an innovative agenda and a condition of innovation is risk-taking. How do you see the balance in managing the elements of risk-taking within a health and government setting?
It's a hot topic at the moment, isn't it? That Silicon Valley attitude of fail fast and fail often, and some people...
To get to your end point.
Yeah, and so, some people would say you can't do that in healthcare. I disagree a little bit. I think we can. You know, do you want to go into a live hospital environment and start trialing out some frontier technology for the first time? Probably not. But to Belinda's point, to bring in the users, whether it be a clinician, well, it needs to be a clinician and a consumer together. That fail fast and fail often, I think, is where we see some of the breakthroughs, and not punish people for failing, because it's just part of the journey to get to the point where you actually get a breakthrough. We see that in medical research all the time. You know, there's lots of failure, and it's just part of the journey. But we need to find a way to be able to be comfortable with that in healthcare. That doesn't put the patient at risk, of course. So I'm always a bit of a fan of try to give it a go a few times, and hopefully you might not get it on the first, but you might get it on the third or the fourth.
I think the issue of risk in these settings is already very well understood and known, and there are parameters, and we have structures that make that safe for consumers, and all of these things would be undertaken within that framework.
Yeah, and Julie's probably parts of the agenda here is actually delivering the same service, but just using a different mechanism. So we wouldn't test something on a knee replacement without that's a completely different scenario. But talking about providing a consultation or some opinion or some specialist advice, this is really around a different mechanism of providing that, and hopefully one that is actually more convenient, that is more timely, that doesn't have you waiting, and actually we can probably provide more of that advice, quicker and to more people than we could in a traditional model. So there is the thing that we haven't done well in health is say, what's the risk of us not doing something different? And I think that's probably that's the thing that I think we're going to need to struggle with different. If we keep the same models forever, then that's inherently risky as well.
Thank you. One last question from the digital world. Does SALHN already use digital technologies and services, or just Sunrise EMR as an electronic database? David?
Yeah, no, we do use digital technologies. We're exploring a lot of different ones too, but EMR, Sunrise EMR is the most recent one. But there's different types of, I guess, programs. There's iCarNet, we do, telerehabilitation. There's half a dozen or so that are utilised around the system. Virtual consultations. So no, there's quite a lot. Some of the sort of AI enabled ones. We're getting more into the exploration stages at the moment, but things like robotic or guided surgery is used, but under the research space, more in the precision medicine is used as well. So moving there, but the reals of some of the latest technologies we're sort of exploring from what are some of those things that we could do in the remote consultations, the remote monitoring, I guess physiological as well as environmental supports that you can put around the place.
And to add to that, David, another question that's popped up, it says people seem to be nervous about data security, so my health record, etc. How can we reassure consumers and the community that their digital health information is secure?
Yeah, within SALHN itself, so there is Digital Health South Australia that is actually the governing piece across the board. So that has a lot of security advice. Anything new that we SALHN or a researcher or anyone else has to go through has to meet all of the requirements in those. And there is a governance piece through Belinda's Medical Centre, through SALHN, through the department, so on and so forth. So very strong governance. The other thing, and firewalls and security and all those things. The other thing is some of the new enabling technologies. I would be providing consent to say I want this to happen or I don't want this to happen. So if I don't want my wearable in the future feeding into my medical record, that's okay. We will be providing a service shortly for some of our elderly patients at home, and if they don't want some of the supports around the home, around some of the environmental monitoring, then we won't put it in. That's fine. And down the track, the consumer could choose where they want an alert to go to, or if they don't want an alert at all. So there's just different ways that we can tailor that for people, and there would be a consent process for each of them.
Thank you. Are there any questions? I've got another question from the audience.
Thank you for that. It's been very interesting. Just further to what you were talking about there, given what just happened with Facebook and WhatsApp and Instagram completely blacking out for a significant period of time and the impact on personal life but also potential businesses, presumably, as far as I'm aware, that hasn't really happened before. Those sort of instances, is that something that, is taken into consideration when you're looking at the different technologies?
So that's a question about the systems that support technology in this situation and the security of those systems in terms of being constantly available to us. Yes.
I'll toss across to Terry shortly. Yes, it is. There's also something called high availability infrastructure. That's something that we're looking at, and that's sort of the amount of downtime that would be reasonable in a I guess an ecosystem that is heavily reliant on some of those things. Now, we don't have. We don't have the level. We're talking, minutes a year of what you would expect as downtime. So that's a piece of, digital infrastructure that certainly we're considering in SALHN as we go through those different bits. We have had discussions with Digital Health SA as well around what those models look like. So yes, that sort of high available infrastructure is really important. Then, as you say, the security side and things, absolutely. Anytime anything happens, really around the world, we get the alerts from it that goes through. And I'll attest to having two board members here. We were asked about it quite a lot at the board level too. How do we ensure both our, paper records, our medical records, but also as we move into cloud deployed places, how do we make sure that's right too? So lots of checks and balances in that space.
Any other questions from the audience?
I might if I could just add to
yes,
that,
absolutely,
if that's okay. I think, look, it was a high-profile outage because it was Facebook. It probably happens more than you think, but as David said, usually the disaster recovery is in place. That you might have a little bit of downtime, but it doesn't really mean that the information has been lost or corrupt. It's just it hasn't been able to be accessed for a period of time. But with modern technology, and I'll be semi-controversial now. So one of the I promised I wouldn't, but I can't help it. David mentioned cloud, and there's a misconception, I think, particularly in healthcare, that everything, all the information has to be within the physical four walls of your organisation. So sitting on a server somewhere in your basement, and that somehow is more secure than something being on the cloud. It's not true. The cloud infrastructure is so much more sophisticated and secure than keeping your information, what we call on premise. So I think we're starting to see healthcare organisations seeing the advantages of using cloud infrastructure, where the disaster recovery and the backups and the on time and all of those good things that you need to do are just an inherent part of buying cloud. And it also allows you to kind of pick and choose different vendors that you deal with, and it reduces the physical footprint that you need to keep the lights on from a technology point of view. And if I may, I just wanted to go back to the previous question about security and privacy in My Health Record. I think the Digital Health Agency are partners and good friends of ours, and I think they did a pretty decent job. I think the PR around it was terrible. You know, when My Health Record was rolled out, the debate was about what are people doing with my information, rather than the benefits of what that will ultimately do. You know, I think no one can argue, if you're sitting in front of your doctor and you've just been diagnosed with a severe chronic disease, do you want that doctor to have all of the available information at their fingertips to make an informed choice about how they treat you? Of course. And one way to do that is to have something like My Health Record, where information can be accessed, and the crowdsourcing of information for the greater good for you as an individual patient when you're sitting there and potentially having that awful news given to you. So I think, you know, the idea of it is sound. Unfortunately, we got into it was more of a debate around security and privacy, which is important, but probably shouldn't have been the leading factor in something like My Health Record, which I think is a good idea.
There's just another question's popped in, so if we can have another 5 minutes, that would be great. How do we build up confidence in our patients and community that healthcare via digital is not inferior? That's a really good question. Belinda, that's something that you might have some experience in.
Building confidence, that's an important part of that journey of identifying appropriate technologies to use, and then implementing them in a way that sets up expectations, but also monitors the outcome. I think it's really important to look at research and piloting some of these technologies to be able to actually share some of the findings in order to instill that confidence, so that this is not just a technology that has been picked up and plopped into the system. It's something that has the research and the evidence behind it in order to expand and roll out. So sharing some of those steps along the way, I think, can build confidence. And speaking to the medical health records, it's again about expectations, setting expectations, and how the technology is introduced, and then also responding to feedback in a timely and appropriate way, so that if the expectation is that there might be some challenges, and you're welcome to provide feedback, and here's what we've done with that feedback. That kind of cycle, I think, is an important part of that process.
Absolutely. Thank you. If there aren't any more questions from the audience, I'll wrap this up. I'd like to thank Terry, David and Belinda for coming today and sharing their experiences with digital technology in the health setting. And thanks very much to our audience for coming today and the people that have joined online. Community chats, which is what we've called these sessions, will be held over the next 8 weeks. So there's a number of opportunities that you have to participate in a conversation about health and what health means to you and what you would like the future of health to be in our community. That will lead up to our annual public meeting, which is on November the 25th, where we hope to be able to share with you some of the things that you have shared with us to complete that cycle of thinking and learning. So we encourage you to participate in those activities and to spread the word that this is happening. We're asking the community, we're able to access what is available through using this QR code, and we're going to ask the community what they would like to talk about. So a couple of the sessions that we're having are dedicated to the topics that you would like to cover, rather than us creating content for you and creating topics for you to explore. We'd like to understand from you what you would like to explore. So there is a way of telling us that, and you can use that QR code. It takes you to the Southern Health Community Hub, which has got lots of different resources on it. So that is a way of connecting into this program and telling us what you think. Again, I'd like to thank everybody involved in the planning of our strategy and attending community chats, our first community chat today. It's really pleasing to me to be able to have a conversation with our community to actually launch what is our blueprint. And we'll see you all at the next Community Chats event. Thank you.